Hey everyone, and welcome to today's explainer. Today we are tackling a very literal pain in the knee. You know the one. It's a condition that totally plagues athletes, weekend warriors, and honestly, even those of us who just sit at a desk all day. We're going to break down the mechanics, the mysteries, and most importantly, the actionable solutions behind one of the absolute most common causes of knee pain out there. Let's get right into it.
Think about this for a second. Have you ever stood up after a long 2-hour movie and just felt this dull, nagging, deeply frustrating ache right behind your kneecap? Or maybe you felt that exact same sharp twinge when you're just walking down a flight of stairs. Well, if that sounds familiar, you've likely experienced what clinicians affectionately call the movie theater sign. It's a classic hallmark of patellofemoral pain syndrome. It is incredibly common, highly relatable, and today we are going to figure out exactly how to fix it.
So, here's our roadmap for this explainer. We'll start with the runner's knee mystery, then look inside the pulley system, figure out who gets it and why, talk about diagnosing without an MRI, and finally, map out the road to recovery.
Okay, Section 1, the runner's knee mystery. Let's dive right in and unmask exactly what this mysterious joint ache actually is.
Patellofemoral pain syndrome, or PPFS for short, is usually just called runner's knee. The medical consensus describes it as pain occurring around or behind the patella, your kneecap, that gets worse during weight-bearing activities when your knee's flexed or bent. But here is the absolute best, most empowering part of this definition. PFPS is a mechanical issue. So unlike conditions like osteoarthritis or chondromalacia patellae, having PFPS does not mean you have permanent structural cartilage defects. Your knee isn't deteriorating, I promise. It's really just temporarily malfunctioning. And hey, if you're dealing with this, you are definitely not alone. A retrospective review of a massive orthopedic database in the US actually estimated that around 1.75 million patients experience this condition. That's roughly 6% of the population they studied. It's a wildly prevalent issue, especially among active adolescents and adults under the age of 60. So yeah, you're in good company.
Moving on to Section 2, inside the pulley system. To figure out how to fix this, we first really need to understand how this beautifully complex biological machine operates.
Think of your patella as a lever within your leg. It's this super clever design that actually decreases the amount of force your quadriceps need to extend your knee. Pretty cool, right? But for it to work properly, that kneecap has to track perfectly within the groove of your femur, and this relies on a super delicate balance of dynamic and static stabilizers. Now, there's a specific muscle called the vastus medialis obliquus. That's a mouthful, but it's basically the inner part of your quad, and let me tell you, it is an absolute hero muscle. It's the primary dynamic structure providing this crucial medial, or inward force, to keep that patella stabilized and stop it from being pulled way too far to the outside.
Now there's something called the Q angle, which measures the overall force of the quadriceps. You figure it out by drawing an imaginary line from the pelvis down through the center of the patella to the shin bone. Here's the thing. When the lateral or outside forces overpower those medial, inside forces, the kneecap begins to maltrack. It's kind of like a tiny train slipping off its tracks. And every single time you bend your knee, that derailed train rubs improperly. That rubbing stimulates nerve endings in the surrounding tissues in the fat pad, and boom, that's exactly what creates that nagging pain you feel.
Which brings us to Section 3, who gets it and why. Let's dig into the demographics and triggers to figure out what throws this delicate machinery off balance.
So, who actually gets runner's knee? Well, research shows a pretty distinct demographic trend. Females account for about 55% of PFPS cases, making women slightly more likely to develop the condition than men. And this isn't just random. It's actually often attributed to biomechanical differences, things like anatomical pelvic width, which directly affects that Q angle we just talked about. There's also a higher prevalence in women of something called dynamic valgus, which, speaking of, we're going to cover right now.
So what are the actual triggers? Well, at its core, PFPS is an overuse injury. Basically, it means you just loved your sport or your daily run a little too hard. High-load activities like running, heavy squatting, and constantly climbing stairs are classic triggers. But it's not just about what you do, it's also about how your body moves. We just mentioned dynamic valgus. This is a movement pattern where the knee collapses medially, or inward, when you land from a jump or drop into a squat. That puts immense lateral tracking pressure on the kneecap. You add in a little quadriceps weakness or some foot hyperpronation, which is where your feet roll inward way too much, and you've got yourself the absolute perfect recipe for runner's knee.
Section 4, diagnosing without an MRI. Let's shift over to the clinical side of things and bust the myth that you always need expensive imaging to figure out what's wrong.
Now, the differential diagnosis for knee pain is huge, but PFPS is highly distinct from actual structural damage. The absolutely crucial point here is this. PFPS involves a dull ache during weight-bearing flexion. On the flip side, if your knee is locking up, aggressively clicking, or literally buckling because the joint itself is unstable, those are signs of an internal derangement, like a meniscal tear. And that is a completely different puzzle to solve. But for PFPS, those structural defects are absent, which means an MRI is generally totally unnecessary unless conservative treatments end up failing after a few months. So instead of ordering MRIs, doctors mostly rely on functional tests. For example, simply experiencing pain during a double-leg squat right there in the doctor's office, that test actually has a 91% sensitivity for diagnosing PFPS. Seriously, 91%. It is by far the most sensitive way to catch this syndrome. Your doctor is also going to check your gait, your posture, and maybe even look at the wear patterns on the bottom of your shoes. They do all of this to really pinpoint the mechanical root of the problem.
All right, Section 5, the road to recovery. Let's take all of this and build an actionable treatment plan. Because, hey, once we know it's just a mechanical tracking issue, we can actively fix it.
You'll be happy to hear that the treatment hierarchy for PFPS is wonderfully straightforward. Phase 1 is all about acute pain management. We're talking relative rest, ice, and maybe a short course of NSAIDs to just calm down that immediate inflammation. But Phase 2? That is where the magic happens. Targeted, individualized physical therapy is the absolute gold standard here for long-term relief. You literally have to train your muscles to hold that patella on its tracks. And then finally, Phase 3 involves temporary adjuncts, things like orthotics and patellar taping. These just help support the knee while those muscles are busy getting stronger.
Seriously, if you take away just one actionable piece of advice from this entire explainer, please let it be this. Weak hips equal sore knees. I know, it sounds kind of counterintuitive, but the science is crystal clear on this one. Strengthening your core, your hip abductors, and your external rotators is the absolute secret to fixing the knee's pulley system. Strong hips are what prevent that inward dynamic valgus collapse we talked about earlier. They ensure your thigh bone stays perfectly aligned right under your kneecap during a run or a heavy squat.
Now, while you're putting in all that hard work to strengthen your hips and quads, kinesio taping can be a really fantastic short-term buddy. The tape is specifically placed to mechanically guide the patella and help improve that tracking. And the evidence backs this up. It suggests that when you use taping in the acute phase, alongside a robust exercise program, of course, it can temporarily relieve the pain. And that's a game changer, because it allows you to actually perform your physical therapy exercises comfortably, without wincing every 5 seconds.
Now, you might still be sitting there wondering, well, isn't there just a quick surgical fix for this? Well, the source literature is incredibly emphatic on this point. They state, and I quote, "Surgery should be performed only after conservative measures have failed. Surgery is considered a last resort," end quote. Dedicating time and sweat to physical therapy for at least a few months is immensely more effective and significantly safer than rushing straight to the operating room to release tissue or scrape the kneecap.
At the end of the day, the mechanics of your body are incredibly responsive if you just give them the right input. Patellofemoral pain syndrome is not a sign of a failing joint. Think of it more like your body's check engine light, just asking for a little better muscular support. So my final question for you is this. Now that you know your stubborn knee pain might actually just be a hip problem in disguise, how are you going to change the way you move tomorrow? Thanks so much for joining me on this explainer, and hey, here's to unlocking healthier mechanics.